Morning, everybody.
Welcome again to the 2024 Conference on Holoprosencephaly. We're welcoming back folks who have been with us since Sunday, and those of you who are just joining us today, welcome. We're glad you're with us. We've had an exciting past couple of days, and wouldn't you agree, Steve? It's been fun. We've learned a lot.
It's been fun and it's been full of glitches, and it's been interesting, and I appreciate a lot of folks, kind of being patient with us. The one thing I have to always remind people is, since we're a nonprofit, we don't have an IT department. So usually it's one of us trying to figure out what's going on. So I apologize yesterday. I think people might have seen me with my head down a couple times on my phone, but I was trying to help folks maneuver through trying to get onto Teams, and there's a Teams chat feature. And so I had a lot of folks sending me chats, and there were things in there. And so we were just trying to troubleshoot. And, my wife Leslie's kind of moderating everything, and she was trying to do stuff at the same time. And so we just, I think at one point, I even got one of the dogs involved because I thought if I can't figure it out, maybe one of them can.
Yeah.
But just a reminder to everybody, because that's another thing that's popped up is if you don't get an email that has the recordings, at the end of the day or the next day, everything's going to be on the Families for Hope website later this week. And then we'll have the slide presentations, materials, anything that we talk about or that we shared, whatever, we're going to have that on the website for everybody. Because I know there's folks that still weren't able to join us even virtually, whether it's just due to their schedules or being overseas. I know we had a couple folks that were overseas, and it was like 2 or 3 o'clock in the morning, and they're still joining us, here at 10 or 11 o'clock, which I think is really awesome. But we'll have all that stuff, the links to resources that we've talked about and that we'll talk about more. So I appreciate everybody's patience. This is the first time we've tried this. I'm hoping it's something that we can do again. But we may actually get some professionals to help next time, just so we're all keep our sanity during the time of trying to do all this. So just, I appreciate you all. So with that, I'll let Susan talk for a couple minutes.
Well, I just want to encourage everyone to share with us, drop into the chat if you'd like, if you've been with us, if you were with us on Sunday or yesterday, share some of your takeaways, what you enjoyed, what you learned, and also share if you have any ideas about things that you'd like for us to present. We're really excited with this experience about sharing more information that will be of benefit to all of our families, and having some of the folks back. I noticed yesterday there were comments that expressed interest in learning more about certain things. We had a wonderful presentation from Dr. Nancy Clegg and Dr. Paul Krushka. So if there were things that you want to delve deeper into or would like more information on, please let us know. It's some things maybe that you haven't seen in the past couple of days or that are not on our program this time. Let us know that too, because what we'd like to do is more podcasts, more webinars, be with you more often, bring you information and resources that are going to be beneficial to you. We're especially excited about our mental health initiatives. On Sunday afternoon, some of you participated in a wellness session where you learned 4-part breathing with Dr. River Sturdivant and Tammy Winfrey Harris. I hope that you've been able to practice that a little bit and center yourselves and take that time out to just breathe and be. Let us know what you thought about that if you participated, how you're doing it, if you're able to incorporate it into your day. But these are some of the things and some of the people that we'd like to have back with us and just spend some time with them, sharing more and having you be with us to be exposed to more wellness ideas, proactive mental health and emotional wellness exercises, but also taking care of ourselves just where we happen to be. So, being able to support one another and bring you things that just help you in your day to day, which we all know, all of us have those stressful times that, are really, really difficult for us at times, and we need that support. So with this mental health initiative, we want to welcome everybody to be able to come into a safe place where we can support one another. So, yeah.
Yep. So, before we get started with Seth here in a few minutes, I was going to hit on a few things that we kind of talked about, and because a lot of folks have asked us about volunteering, and so obviously to be able to do what we do, volunteers are huge part of our organization, and so one of the things that we probably need the most help with, I think, is going to be website and analytics. Obviously, like I said, we had a little bit of difficulties with trying to get everything going with this virtual conference, but folks out there, we'd like to revamp the website, and I just don't have time to do it. But I'd like to be able to have folks that maybe have a passion for that might be interested in it. And it's one of those things where I'd love to hear from the families on what you would like to see. I know that one of the things we've talked about is a different landing page, so that as folks come into the website, the landing page is more of kind of something that's there, and then you can move to the things that you're interested in, and just make it easier to navigate. And then we've got a big thing with our social media. We have some new board members that are going to be coming on that are going to be involved in that, but social media is huge, and we want to continue to kind of grow that piece. And then we have just our other things that pop up during the year. I mean, we have our costume contest, which will be coming up here in the fall in October. We always have our HP Awareness Week, and then our fundraising events. But I really want to focus when we have HP Awareness Week next year. I think this last year we had some cool stuff that we did. We did the movie night. That was interesting, but I really would like to get more and more families involved in it, and really just try to figure out a way to expand HP Awareness Week. And I think we had a good springboard this year, wouldn't you say? I mean, just with more stuff that we did. And so, and then the other piece is that we've kind of missed the boat on a little bit, and we've tried it a couple of times, is parent to parent. Obviously as parents, the biggest piece and the biggest way to advocate for our children is through the support we have with each other, where you can bounce ideas off of each other, or you can make suggestions, or when we have new families that come in, trying to connect them with folks in their area. That was a big thing I heard yesterday when we were talking about it, where I have folks that live in Baltimore, in Pennsylvania, and New Jersey, and probably even further on the East Coast. I know we have folks in West Virginia, and so when you get into that section of the country, everybody's within an hour or two of each other. And I'm not saying that, hey, y'all need to be able to go drive to each other's homes or whatever, but maybe there's a place in the middle, or something that people can meet at, and I really want to get back into that more. We had that in Indiana. There were several families here in Indiana, and it's like, okay, well, within Indiana we can get anywhere within a couple 3 hours. And I know there's other, we have folks in Texas and Kansas and Missouri and everything else. So I really would like to get to that point to where we get back to that. So if anybody would be interested in that, or any of the other things, like I said, you can reach Susan and I. You can email me directly, or you can send it to the info at, and then that comes to both Susan and I, and then we can follow up with you. But those are just things that we're passionate about, things that we really want to do more of. Like I said, we're here to serve the families, and you guys are what drives us.
Yeah.
Even in the midst of all my health issues I've had in the last couple of years, Families for Hope, probably the one thing that's kept me going and kept me energized. And Susan can
Absolutely.
attest to that. So
That's for sure. And, as we said yesterday, we are Families for Hope. It's for families, with families, and by families. And it's been that way from the very beginning. You guys do a wonderful job every day supporting one another in our Facebook groups. That's great. But as Steve said, we also want to expand. There are people, and we've heard it over the past couple of days, who are very interested in knowing who's around them, who's close by. And if we can build these regional groups, these groups of people who can reach out and have that experience of face to face and shoulder to shoulder throughout the year, or any time that you need it, and not just every other year when some of us, certainly not all of this huge, wonderful community, can come together and put a name, face with a name, and be together. If in our areas, then that is something that folks can reach out and be together when and as needed, and enjoy that type of community that is so wonderful and experienced online in our Facebook group. So anybody who is at all excited about that or being a part of that, we welcome you. We want to talk with you about it and have you brainstorm. We have a model. We'd like to expand on that and improve on that for parent to parent and family to family. We just really want to drill down and make it more powerful and ensure that it works. So if you're excited about that, if you want to be a part of it in any way, then we welcome you. We'll, as Steve said, info at familiesforhope.org or either one of our email addresses. We welcome you to be a part of that effort with us. So stay tuned for that. Stay tuned for that, and we're going to talk about that more. And with you and have more about it on our podcast. And so you'll have more information as to what that's going to look like. So we mentioned our costume contest. We mentioned Awareness Week. Those are wonderful things to enjoy and to be a part of. So we're very excited as we're looking toward the end of summer and fall coming on for that costume contest, which is always so much fun. To see the kids in their costumes and to have that activity in our community. So looking forward to that.
Leslie just wrote it on her whiteboard. I like I said, we're not professionals here, so but she wanted to remind me. So on Wednesday night, Leslie has posted out there, and we do Wednesday night she hosts a Zoom call, and it's for expectant parents. And so we've had some people that have joined on recently, new people that have become aware of Families for Hope that are expecting a child to be born with HB. And so they've reached out to us, and Leslie has that Zoom call from 8 to 9 Eastern time every Wednesday evening. So if anybody's on here today that is an expectant parent, or if you all, in your within the Facebook groups and things, if you happen to run across someone that maybe is new and is reaching out in one of our groups and says, hey, I'd like to get more information. I mean, we always try to plug them in with the Carter Centers, obviously, to get them going with that. And like Nancy said yesterday, it's a partnership with them and us, and also with PCPs and OBs and things. But if you happen to hear of anybody that's looking for information, then guide them to the website, which has the information on there for Leslie's call. And she gets on there because she has a much different perspective having been, a mom that carried a child with HPE, I mean, it's not even something that I can begin to understand or would. I mean, it's the bond between mother and baby like that is very unique. And I know that. And so I think what she does with that is awesome.
Dads can call too.
And the families like it.
Dads can call.
What?
Dads can call.
Oh, and dads can call too. So it's not just moms. See, I told you we're unprofessional here.
Unprofessional.
I can't hear anymore, so I'm going deaf, I think. I need hearing aids. But anyway, I digress. But so yeah, dads can call too, and get in, can talk to Leslie too. Or I mean, if dad was unsure, I could always try to jump on the call and everything, but I try to let Leslie handle that. So I think we're probably about ready for Seth. Most of you, I think, know Seth Berger. Seth's been around for a while. He was with, as Paul mentioned yesterday, he was just a young, what do we call it? A young fledgling geneticist, maybe, or resident, with Max and Paul. I remember seeing Seth at one of the conferences, I think probably when we were at Bethesda, maybe not. I don't know. Seth will remember. He's been around for a while. But anyway.
I know he's familiar to many of you.
Yeah.
We don't want to make him feel like he's ancient, but yes, he certainly has been a part of this organization's history, and I know lots of you know him and love him and really look forward to the information that he always brings us at conference time. So we're really thrilled to have him with us again this year. Seth Berger, MD, PhD, and he's an assistant professor of genomics and precision medicine and pediatrics in the George Washington University School of Medicine and Health Sciences. He's done so much and is doing so much in the area of holoprosencephaly research. And so it's always wonderful to have him come and bring updates and share with us information that we all find very useful. So without further ado, I think that I'll go ahead and turn things over to Seth. Good morning.
Wow, I'm floored by that generous introduction, even though it says I'm old. And along the lines of me being old, actually, I was recently promoted. I'm now an associate professor at George Washington University. So,
nice. Okay.
Thanks a lot in part to the work that have come out of working with your organization. So thank you very much for that. I'm going to talk today. I know Dr. Krushka spoke yesterday a lot about why one does genetic testing and what genetic testing shows. And today I'm going to talk a little bit about some of the limitations of genetic testing and things that we miss on genetic testing and why we're still missing them, and the way that, some of the families in this organization have helped me figure out why some of the things that we're not finding on genetic testing are not being found and how we're actually now able to find them. So I'm just going to, the basic agenda for this talk is I'm going to talk about some of the research challenges in clinical genetic diagnoses. I'm going to talk about some of the recent advances in holoprosencephaly in terms of genetic diagnostics. We're going to move on to talk about some newer technologies for sequencing that we're applying in holoprosencephaly. And I'll end by plugging my research study that if anybody wants to participate, we have people who can come to your house and collect samples, so no matter where you are in the country. So, as you know, I don't have to explain to this group what HPE is. You're all living it, you all know what it is. But I just want to conceptualize it a little bit differently because from my point of view, HPE is not really a end-all diagnosis. It's a symptom of something else. And in this way, I mean, you have, often it's a genetic diagnosis, sometimes it's not. But we know that in people who have a clinical diagnosis of holoprosencephaly, around 20 to 50% of the time, we can find a genetic diagnosis. And that genetic diagnosis explains why that person, when they were developing, their brain developed how it did. Now, there are different types of genetic diagnoses that lead to this. Paul spoke to yesterday, he might have even showed a similar slide as this one, and talked about how, about up to half the time you can find large chromosomal differences. So like the big pieces of genetic material are either arranged differently or missing pieces, extra pieces. And again, about 15 to 25% of the time, there's only a single gene that has a problem with it or a change in it that led to the developmental difference. Oh, I should also note at this point, I'm going to try to keep this talk easily understandable to anybody who has a PhD in genetics, but I actually hope to keep the hope to bring home points that will be useful for everybody here. And feel free to throw questions into the chat. I'm not able to see the chat as I go, but if someone says something in the chat, please interrupt me, and I'm happy to talk. So now the context of, single gene disorders is really in the context of the last decade, because over the last decade, our pace of gene discovery, of finding out what genes lead to specific human diseases, has really, really taken off, mainly to changes in our technology and how we do sequencing. And over the last, 10 years, there's been, average of 100 or 200 genes per year that have been discovered. And that means that over the last, 8 or so years, there's been about one holoprosencephaly gene discovered each year, every year. That pace has slowed down a little bit since, mainly since Paul went to industry, because a lot of that was driven by Paul. But we're trying to, pick up the pace now that we have the data that he used to work with. So what are really the clinical problems when you do genetic testing? Well, I mean, there's a really open question, like what's the best strategy for clinical testing for genetic disorders? And I don't know the experience of those on the call, but depending on who's doing your diagnostic workup, I mean, for someone presenting with holoprosencephaly, they may end up saying we're going to only sequence 4 genes, or we may only sequence 15 genes, or they may say we may sequence 20,000 genes and only talk about the ones that we know cause holoprosencephaly. It's really an open question, and it depends on where you live, what your insurance is willing to pay for, when did your doctor train, all of these things come into that. But it's still not clear what the best strategy is, although guidelines have now really moved towards doing testing for more things rather than fewer things. At the other end, at the bottom here, the question is, what do you do when you have a genetic diagnosis? And that's really, I mean, that's where family groups like Families for Hope come in, because you're going to be driving what the evidence is of the best way to treat children with holoprosencephaly, how to best manage what are the needs of the families, and I mean, right now, it doesn't matter the actual genetic cause for the most part. Treatment is very symptomatic and managed empirically. So that's why really the evidence gathered by organizations such as this one are going to be so important. Really, I fall in the middle here, though, in like, how do we know if a genetic variant causes disease, and trying to understand what are the genetic variants that we are not finding when we're doing the testing. So these are some of the different sequencing strategies I mentioned before, where some people just look at a small set of genes and other people will look at basically all the genes. And there's a lot of trade-offs in terms of cost, turnaround time, how likely you'll find your answer, how likely you'll miss your answer. So these are things to keep in mind. But when you do, and no matter what your sequencing strategy is, everybody has genetic variants. And when you find a genetic variant, you have to determine, is this a problematic genetic variant, or is this just something that tells you where your family's from and doesn't mean anything? And now I like to put this in a historic, and I'll come back to that. I like to put this in a historic context because before 2015, it was the Wild West of genetic testing. And you would order a test from one lab and they would say, we found a likely mutation. Another lab would say, we found a possible disease-causing variant. And, they did not use the same language. In 2015, they came up with a standardized language of how do we describe genetic changes. Namely, they said, if you are sure a variant let's say this variant in, let's pick a holoprosencephaly gene, sonic hedgehog, causes holoprosencephaly. If we're sure that this specific change does, we can call it pathogenic. If we're sure that this change is just something that we see in the population and doesn't cause developmental problems, then we can call it benign. However, if you're more than 90% certain, you can add the word likely. So I'm 90% certain that this variant in the right person will cause developmental differences, then it's likely pathogenic. I'm more than 90% certain that this variant in the right situation doesn't cause any problems, then it's likely benign. But that leaves this huge wasteland of 90%, 89% certain it doesn't cause a problem to 89% certain it does, and that's called variant of uncertain significance. And this is actually a big problem across genetic testing because the amount of evidence we have to get to that 90% threshold is actually fairly challenging. And specifically for holoprosencephaly, it's actually particularly challenging because many variants are private, meaning that you'll find a variant in a family and it's unique to that family. No, the two families are not going to have the same exact genetic change. There are some recurrent where we'll find the same variants in more than one family, but often you'll find a private mutation, and I don't know. Incomplete penetrance and parental mosaicism is common in holoprosencephaly. This is actually, it's very common for a parent to have a known pathogenic HPE variant and have minimal to no features, whereas their child can have complete or a lobar HPE. So this means that using the inheritance of a variant to determine if it's disease-causing does not actually give us as much information. Missense variants, or just single-letter changes, are also common in many of the HPE genes. And this is also particularly challenging for classification because those are very hard to classify. If a genetic change completely deletes a gene or cuts a gene in half, I can tell you it breaks it. If it's a single typo in like that whole like thousands of letters, it's much harder for us to predict. Now, we also know that we have a lot of practical things. Parents are not always available for sequencing, so I can't always tell you if a variant is a new variant or not because I can't always sequence parents. And the fact that holoprosencephaly occurs across all ethnic groups, it makes it very hard to differentiate common variants in populations that are not represented in our databases from rare variants in the overall population. So these are things that particularly affect HPE that can make variant classification very challenging. So why is it problem when you end up with a variant of uncertain significance? Well, I like to put this in the two categories of the delayed diagnostic closure and the premature diagnostic closure. So a doctor who is relying on that variant of uncertain significance and says that I think this is the answer may be missing a different answer that may have different treatment implications. Similarly, a doctor who is treating who sees a variant of uncertain significance and doesn't believe it and is still looking may be missing an opportunity to treat as well. So these are subtle differences, but they do actually lead to differences in treatment decisions. So I'm going to talk about a few papers that came out, mostly out of the Munka lab, and with that Paul Krischka also led. But then I'm going to talk about our ongoing analysis that we are currently still in the process of. So I'd mentioned parental mosaicism as being a player in holoprosencephaly, and this is actually something that I think is very interesting because the idea is that if you have a new mutation in a child, so DNA copies, it makes a new mutation. Typically, we think of that mutation as being in every cell of that child, that mutation was in the sperm or the egg. However, sometimes that mutation occurs before the sperm or the egg. It comes while the child is, after a few cell divisions, so it's not in every cell of the body. Now, that's called mosaicism when you have a mutation that's not in every cell of the body, but if it makes it into the germline, into the gonads, you can have sperm or egg cells that transmit this variant so that in the child, it's in every cell of that child's body. So what we had found is in a cohort of Holoprosencephaly families, we found 20 cases where the variant was called as being new in the child, but in 5 of them, we were then able to find the variant at low levels in the parent's blood. Now, what does that mean for that parent? Well, it does mean that that parent has a higher risk of having a second child who is affected. Typically, when we see a child who has a de novo variant, we would basically tell the parent, oh, there's a 1 to 3% chance because I don't know whether there's germline mosaicism. But for these parents who we found this mosaicism in, it means that we were able to tell them there's up to a 50% chance each time they get pregnant of their child having this diagnosis. In fact, one of these parents had microform features of holoprosencephaly herself. So the take-home point is that mosaicism is actually more common than we realized before this study, and that it affects recurrence risk. And actually, there is clinical testing that is available for this. So Paul's company, GeneDx, offers a mosaicism testing that if you have a apparently de novo variant in the child, you can do the mosaicism testing in that parent to see if the recurrence risk is higher than you would have thought. It's not clear whether this test is always covered by insurance, and it is not, if it detects it, great. If it doesn't detect it, it doesn't rule it out. So that's the other thing to know. So if it detects it, we know you have increased risk, but if it doesn't detect it, we don't know how it decreases your risk back to background levels. So I did a little bit talking about variants of uncertain significance, and this is an example of a study that came out a few years ago now, of where they were trying to study variants of uncertain significance in one of the genes that causes HPE. And the way they did this, it was actually a very clever assay where they basically created zebrafish who had holoprosencephaly. And they found that if you injected a working copy of the gene into the egg of the zebrafish before it developed, you could prevent it from developing holoprosencephaly. So therefore, they then tested a bunch of different variants that were found in people and said, do these variants rescue the zebrafish or not rescue the zebrafish? And what they found is out of the 120 or so variants that they tested, a bunch of them did not rescue, well, a bunch of them rescued the zebrafish, which basically means you are probably not causative for holoprosencephaly. A bunch of them did not rescue the zebrafish, which is consistent with they were probably causing HPE, the person who had them. And then a bunch of them were in this middle range where they rescued the zebrafish some of the time, but not all of the time. And that they interpreted as what we kind of see in people, how I mentioned before, the incomplete penetrance, where you can have a parent who has the same variant as their child, and their child has a lobar, and the parent has essentially no features. So this is something that we were able to recapitulate in the fish and show that these variants are more likely to have that incomplete penetrant phenotype, and these variants were maybe less likely. And this is, again, clinically useful information because they were able to use this assay to then reclassify those variants of uncertain significance and basically reclassify about 40% of the variants that they had put in this assay and said that they were able to upgrade or downgrade to benign. And that's important because getting uncertainty on a clinical report can be very confusing to families and very frustrating when you're looking for a reason that something happened. Getting a thing, well, maybe this is it, but I'm not sure, is not often good enough. So really the take-home point is that, these functional studies can be done to upgrade or downgrade some of these variants of uncertain significance, and that these are not clinically available studies. You can't actually go to a lab and get this done for your particular variant, unfortunately. So that's why there needs to be future work towards molecular phenotyping, and that's something I'm very interested in, which I could talk about maybe at the end if there are questions. So really, I mentioned before about the pace of gene discovery, and this is actually very important because right now there's about 20 to 40% of people with holoprosencephaly who were not getting a genetic reason where we can find out why it's happening. Now, not everybody has a genetic reason. There are environmental factors. We know that having certain fetal exposures, like the high blood sugars, for example, can be a risk factor, which has genetic risks associated with as well, but a large number of people do have genetic etiologies. And the way we go about finding this is we assemble large cohorts of people and we just sequence everything. And then when we find something that we think is the cause, we start looking for other people around the world that have the same type of genetic change, and then sometimes do functional studies. So these were some examples that came out of the Munka lab before that, which I'll just go through. I mean, this is an example of a single gene that was found where they found like 12 people across the world. I think 3 of them had holoprosencephaly and characterized a new gene for this disorder. This is another gene that was found where the way they were able to find this one was that they found 2 people who had the same exact recurrent genetic change. So when you find the same genetic change in 2 people who have similar features, it is very suggestive. And then this is an example of a group of disorders where it's a complex called the cohesin complex. And it's basically they found that people with dysfunction of this pathway were at higher risk of developing holoprosencephaly. So one thing that all these papers have in common, they all have a table that looks like this in it. And when you get, and the exact details of a table like this isn't important, but essentially that you end up grouping all the people that have the types of genetic changes, and you list all the features that they have and say, oh, here's the type of holoprosencephaly that was seen in these patients, and here are some of the other features, and this is how we define new syndromes. And this is why you need large numbers of people to really define a syndrome. Often you'll see some sort of study that like this in a paper as well that just shows that the gene that they found is expressed in the brain at the right time, that it could explain holoprosencephaly. And you'll see other types of functional studies that show that when you change the expression of a gene in a cellular system, you see effects that make sense with what we know leads to holoprosencephaly. So that's kind of just how we go about defining new syndromes and showing that these are related to HPE. So really the take-home points from that is just that it takes really a lot of cases to define a new disease gene relationship. There are more genes still to be discovered, and we're working hard to do it. And knowing the specific gene can help predict recurrence risk. So for example, one of those genes up there that I mentioned before is actually X-linked and can be coming from a asymptomatic mother, for example. So knowing the specific gene can also relate to syndromic features. So some of these are associated with holoprosencephaly with GI issues. Other ones are associated with, I think, endocrine issues. So, I mean, it helps you know what other things to look for. So I'm part of a consortium called the Genomics Research to Elucidate the Genetics of Rare Disease, the Berger Consortium. And this is a national consortium that has 5 sites across the country. And we're really not we're kind of disease agnostic, but our goal is to help understand what we're missing with genetic testing and how people who have genetic testing where they don't find an answer, how we can help move the needle and help them find an answer. We're doing this via multiple approaches. This slide is a little out of date because our partnerships have changed, but we're basically trying to discover novel disease genes. We're trying to discover variants not detected on exomes. So if you've had a very broad genetic test and you did not get a genetic diagnosis, we'd love for participation in the study. Our goal is to disambiguate. So if we have variants of uncertain significance, we're trying to help understand how we can move those either to be sure that they're disease causing or be sure that they're not disease causing. And then we want to be good citizens of the community to make sure the data gets back out to the community so that we improve genetic testing for anybody getting the testing these days. So the first step we have to do is define what a negative genetic test is. And there's different people define negative genetic tests in different ways. There's no variant reported, but a well-defined phenotype. So if you have HPE and we don't have a clear environmental factor that led to that, and you've had an exome and we did not find anything, we would love for you to be part of our study. We also have patients who have a phenotype that's only partially explained. So for example, as you know, holoprosencephaly has a lot of clinical features, but progressive hearing loss isn't one of them, right? There was a patient who enrolled in at the Families for Hope meeting a few years ago who had holoprosencephaly and also some other additional features of progressive hearing loss. When we enrolled them in our study, we found the cause of their holoprosencephaly, which was a ZIC2, a very common HPE gene, but we also found a mitochondrial variant that explained the other features that this child had. So that child actually had what we call a dual diagnosis. And then we also mentioned variants of uncertain significance as being a major player here. So across our, excuse me here, across our cohort, essentially, we are actually finding out of people with negative testing, we're finding about a 20% positive diagnosis rate. Now, when we look about at this 20% positive diagnosis rate, it's actually coming from a few things. You know, about a third of our new positive diagnoses is the fact that, like I said, new genes are discovered every year. And if someone had their testing, let's say in 2019, and they didn't have a diagnosis then, but a gene was published, like one of those 5 genes I just showed before, since they had their testing, we're now finding that that's why it was missed on the original testing. The clinical lab did not know to report this gene because they didn't know it at the time. This is why everybody who's had an exome that's negative, the current recommendations is every 2 years, you should go back to the lab that did the exome and ask them to reanalyze their data without doing a new sample to see if there's been any changes in what they can report. We also find about a third of the cases are what we call technical limitations. Technical limitations has to do with the fact that exomes don't look at intronic variants. Sometimes there's bioinformatic limitations of what labs will report and how they filter variants. So I'm going to talk a little bit about some of the ones that have come out of the HPE cohort, which is basically a merging of the Munka Lab cohort, plus some additional new families that we've added in via Berger over the last few years. So this cohort currently includes 450 individuals and 171 families who have a child with holoprosencephaly. Most of these, 126 of these, we have a parent, 2 parents and the child. 17 of these, we have 1 parent. 24 of these, we only have the child. And 4 of these, we actually have more than 1 affected child, or more than 1 affected family member. Now, about almost half of these have had a gene panel previously, with about another, 3/4. So, with 65 having had a panel and an exome, 2 just having had an exome. We had 4 people in here who had previously known diagnoses just to make sure that we weren't missing everything, and a couple who we actually weren't sure what their previous sequencing was. To date, in this particular cohort, we've identified answers in 25% of the probands. So 25% of the people in this. Now, out of that 25%, this is the types of things that were not previously found or not previously known. And I'll just talk about some examples. So this is actually one of my favorite examples because we don't talk about doing this on genome that much. But this is a child who has a partial trisomy 13. The end of their chromosome 13 is duplicated, and we actually had this on, so this looks like a microarray, but this was actually done on a whole genome that we could actually see this. And moreover, when we did the short read sequencing, we were able to actually reconstruct the breakpoints of this variant to show that this child has actually a normal chromosome 13, a truncated chromosome 13, and a isochromosome 13 with a neocentromere. This is, I know, very technical and complicated, but it just shows you that historically this would have been 3 or 4 different tests to get to this information, but now we can get to this amount of data from a single test, which is actually pretty cool. Splicing variants are common, and we found a bunch of those. Like here is so splicing variants are things that affect how a gene is put together. So it's a single letter change. if you think about a gene like a choose your own adventure book, and you kind of get to the bottom of a page in a choose your own adventure book, you're like, it says turn to page 7, and you get the bottom of page 7, it says turn to page 9. Uh, Splicing variants are things that errors in those instructions of turn to page 7, turn to page 9, and has you reading pages of the book that you shouldn't be reading or skipping pages of the book altogether. So this is an example of an inherited splicing variant where the father passed on this splicing variant to their child. And this is what we call canonical splicing variant, meaning that we know it's pretty bad. Now, splicing variants that are near exons are easy to find. So this one's within 2 bases of this exon. So exons being the protein coding part of a gene, so it's easy to find. But in our case, and this is also another easy to find one, again, 1 base pair from a canonical splice site. But here's one which is 2,532 bases away from the nearest exon. And this is the type of one that is actually much harder to find, which we're now able to find with our new sequencing technologies. Now, if this family has had an exome, they would have had a negative exome and they would have missed this. But this is one of the types that we are able to find based on this testing. Tandem repeat expansions. This is actually a little bit controversial, but there is a recurrent tandem repeat. So in the gene ZIC2, there's this tract of polyalanines, so lots of alanines in a row. And we know if you have 15 alanines there, you're typical. If you have 25 alanines there, you're likely to have holoprosencephaly. And we found that actually in our cohort of cases who even had previous sequencing, this particular recurrent variant of 25 alanines there was missed in 2 families. That's because this type of variant is a little bit challenging for current sequencing technologies, and we are working with a new sequencing technology now that actually is better able to detect this type of variant. This is a fun one. It's fun for technical reasons more than anything else, but this is a large deletion. So it deletes from here to here, which is basically 20,000 bases. And it deletes a gene called ZIC5, which I don't care about ZIC5 because ZIC5 does not cause HPE. However, it deletes right up to the beginning of ZIC2, doesn't delete any of the coding region of ZIC2, but deletes something called the 5' UTR of ZIC2. ZIC2 is a holoprosencephaly gene, and deleting everything upstream of it will prevent that gene from being made. So this is one that would be missed on clinical testing because often they only look at these thick parts, these coding regions, and it kind of ignore these thinner parts, which are a little bit harder to understand. So here we have a whopping big variant, but it deletes a part that will be often ignored. This is another interesting variant because this is deletes about 4,000 bases away from a known holoprosencephaly gene called TGIF1. This is a smallish deletion, but it doesn't delete any coding region. There's no gene here. However, there's some evidence that this particular region might actually regulate the expression of TGIF1. When you see marks like this in like acetylation, it basically tells you that this might be what we call a distal enhancer region, which means that it controls when this gene is turned on. So we actually were able to do a study in a mouse embryo where they took this region and they put it into a mouse embryo to drive the expression of something. And they do see this weak response in the eye fields that it is driving expression of the reporter, suggesting that this region could be affecting how TGIF is expressed, which might have led to HPE in this family. I just like to show this one because this one's also a really cool variant because this is a intragenic tandem duplication. It copies a bunch of exons within this gene in tandem, so it's one right after each other, which basically breaks this GLE2 gene. GLE2 is another known holoprosencephaly gene, and when you have it, but this type of variant, I just like to show it because it's very hard to detect on exome sequencing, and probably would not be detected by most clinical labs. This is one more example of a deletion. This is a deletion of a gene called DHCR7. The deletion is inherited from the mother. When you have a deletion like this of only 2 exons, it's small, may not be caught on exome. And when we look, this is actually a recessive gene. You need to have two variants, one from mom, one from dad. And when we looked in dad for this one, we found the second variant as this one, a canonical splice variant. So again, I know I'm being very technical here, but this one is actually causes a syndrome called Smith-Lemli-Opitz, which HP is seen in about 5% of cases of this. So really the take-home point is that whole genome sequencing can identify variants relevant to HPE that may not be called on clinical pipelines. Whole genome sequencing can identify relevant HPE variants not detectable by exome sequencing, and that researched genomes may identify variants not reportable on clinical genomes and exome, etc. So this analysis is still ongoing. I think I said the same thing a few years ago. This analysis is still ongoing, but we're making progress. We're hoping to have you know have some more things to tell you soon. We're currently also expanding by adding additional technology called RNA sequencing to this data set, where we're looking at transcription of the genes in the blood, as well as a new technology called long-read whole genome sequencing, which allows us to see methylation and epigenetic changes. So I really need to make sure I thank Paul and Max for a lot of the data there, because they really were instrumental in accumulating a large portion of that cohort over their careers. And I mentioned some of the new technology that we're currently applying, and I have to acknowledge, of course, all the people who were instrumental in putting together this on the CNH and PMGRC side. And so I do want to throw this up at the end here and quickly just say that we are still working to expand our Holoprosencephaly cohort. The ideal candidate is somebody who's had some genetic testing but doesn't have a definitive genetic result. I will be analyzing your families alongside the Munka Lab cohort. If you want to learn more about the study, there's information up there, and you can refer yourself, ask your doctor to refer you, send me an email if you have any questions, and I'm here to answer any questions you might have right now.
So we appreciate that. So I do have, let's see, we had one question that popped in while you were presenting, but I kind of held it until we got to the end here. This is from Rachel, and she's in Baltimore. Her daughter Lily is 22, and she said she's kind of a unique case, and she'd love to bring Lily to you. She goes, I've been searching her whole life to find a doctor interested in her. She said that she has 5 kids and only Lily has issues. However, she has a daughter and sister with type 1 diabetes and wonder if that could be related as well, because she knew that diabetes can be an issue.
So for your specific family, how about you send me an email? Did you catch my email before, Rachel?
She didn't catch it, but we'll get it. We'll get it to her.
So I'm going to put my email into the chat for anybody who wants to email me.
Okay, there you go.
That's great.
So I put my email in the chat, and Rachel, just send me an email. I'm happy to discuss your daughter's case offline. And if you would like to have a clinical appointment at Children's National, we could arrange that. If you'd like to participate in our study without a clinical appointment, we can discuss that as well.
They can send someone to you.
All right, see if anybody. Okay. Don't be shy with your questions.
He had mentioned he could send people to you to get your
Oh, yeah. So
samples.
I know we did this at our last conference, or our conference in 2022. How would folks send a blood test to you? Because if they're not, like, say, in the area where, how would they coordinate that?
No, it's a good question. So specifically, a little bit of details about our research study. I'm part of the Pediatric Mendelian Genomic Research Center, which is, I mentioned, part of the Berger Consortium. Our center has actually recently moved its home to University of California, Irvine, which is the prime site, but we're still nationally recruiting. People who refer to themselves to our study, we have a few options for sample collection. We do offer the ability to mail buccal swabs or cheeks or spit kits to your house, where you can basically just swab your cheek and mail it to us. We also have contracted with a phlebotomy company. So if you're within like an hour of any major city, we can typically send a phlebotomist to your house, and they can draw blood at your house if you'd rather do a blood sample.
Okay. And let's see, Maureen.
Okay. Actually, Maureen, I see your question. So Maureen asked if her son, who does not have HPE, should be tested. So my question for Maureen is, Maureen, does your child who has HPE have a genetic diagnosis? So, the basic answer. So basically, in a family like what Maureen is describing, where you have an unaffected sibling and a sibling who has HPE, typically there's nothing to test for in the unaffected sibling unless you have a molecular genetic diagnosis in the affected sibling. So typically the way the testing would work is you would first test the child who has holoprosencephaly. If you find a pathogenic or likely pathogenic variant, then you can do what we call cascade testing, which means you can test the parents to see if it looks like it's inherited, and you could test siblings to see if it looks like they also inherited it. Uh, it's If there is a concern about, so that is one of the things with HPE is that incomplete penetrance is very common. So we do have a lot of times families where you can have minimally affected family members. So I actually would recommend cascade testing if a genetic diagnosis is found in the affected person in the family. However, if you cannot find something in the affected person, you are not going to find anything in the unaffected person, and it's not worth testing. It's a little bit more complicated if you have a variant of uncertain significance, because it's not clear if a variant of uncertain significance is associated with a risk or not. Uh, so then, okay, the next question, if initial testing revealed that our kiddos HPE was de novo, are there benefits of joining our study? A chance something was missed in mom and dad's testing, we're afraid to have a second kiddo. That's a good question. So if your variant was found to be de novo, then that means most doctors are going to cite your recurrent risk in your next child as being about 1 to 3%. And the reason that we don't say like close to zero is because we don't know whether the variant is in your sperm or eggs, or if it was in just that one sperm or that one egg. Uh, I did mention before there is a test that GeneDx offers called mosaic variant detection. That is one way to assess your recurrence risk, where they can see if they can find the variant in very, very low levels in your blood, or 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 skin or cheek swab or whatever they do it on. Uh, I will tell you, doing that test could tell you if you have a higher risk. Uh, but it does not completely eliminate the higher risk, because if it's negative, it doesn't mean you don't have a variant in your germline. So, I mean, the other thing you could also do is, other options you have is if you have a de novo variant in one child, you can always do things like pre-implantation genetic testing, where you do embryo selection and test an embryo for the variant before you implant. That's always an option as well. But different. Okay, that answer your question to the Hilliards? Okay, and Rachel asked, ZIC2 duplication also indicative of ZIC. So ZIC2 is a finicky gene. Deletions and duplications can both lead to HPE. So is okay. So I mean, so yeah, so ZIC2 duplication, I would say, is as indicative as a deletion of ZIC2. I mean, the classic reason I think about that is like a complete trisomy 13, it leads to HPE, and that is that I think they think the critical gene in there is partly ZIC2. Uh, okay, Tanzis, is the testing available in Canada? Which testing are you asking about? Uh, so I mean, so I mean, there is genetic testing of it. I'm sorry. So there is genetic testing available in Canada. Genetic testing is, I mean, there's a lot of really great geneticists in Canada, and I mean, I don't know exactly the coverage and the insurance situation, but I mean, they I know doctors in Canada who order exomes all the time. So yeah, genetic testing is available in Canada. Okay. So child who has a de novo deletion. Uh, okay, I guess you're talking about your sister, maybe. Uh, okay. So, if your sister had a de novo deletion, I mean, assuming you know the breakpoints and know what was deleted, you probably that's confirmatory, and you don't need any updated testing. You have a reason for her features, and I don't think you need to continue digging for other reasons at this point in most cases. The only reason you would probably need to do other testing is if she was having features that were not explained by her deletion, and that would be something for you to discuss with your someone who's actually had an ability to really examine and know what her features are. But most of the time, you don't have to go looking for a second diagnosis if you have one. All right. I mean, that was great. Any other questions, concerns? So again, feel free to email me any questions you have at any time. If you're interested in learning more about the study, I'll put a link to that in the chat now as well, so that if anyone's interested in the study.
I may have another question for you here.
Okay.
Oh, I know. Yeah, I didn't think about this one earlier. So, do we know if there's any? So, with your studies, are they just in the U.S. or are we looking at folks in other countries? Because no, we've started picking up more families overseas.
So, it's interesting. Research regulatory rules are very, very different from country to country. So our current research regulatory rules are based on US regulations. So Europe has very, very it could be we're currently not enrolling patients in Europe, uh, and which has very specific regulations, and we kind of often we do it as a case by case basis to see if if someone happens to be in the U.S. and consents when they're in the U.S. and gives us a sample while they're here,
Okay.
that they're able to do that. But we're a lot of the logistics of overseas sample collection and the shipping is challenging, and we're not really set up to do that right now.
Okay. Do you know if there's any other countries that are doing any ongoing research for HPE at all?
So, I mean, there are lots of rare disease, undiagnosed disease studies across the world. I mean, England has the whole Genomics England program, and you know, even in the US, there are many different options. There's the Undiagnosed Disease Network. There's our Greger Consortium. I mean, a lot of major, and then on top of that, a lot of major, tertiary referral hospitals have their own undiagnosed disease programs, whether they're officially part of a network or not. So, I mean, it never hurts to ask your local geneticist if there's a research program that they're able to be involved in. Again, I'm very much focused on the diagnostics here.
Right.
One thing I'm very interested in seeing if can be developed for holoprosencephaly would be episignatures, which is a growing field of looking at molecular phenotyping, show it, and for certain forms, particularly cohesin complex disorders, there's really good evidence that we might be able to find one, and this is going to help us eventually turn some of those variants of uncertain significance into diagnoses or not diagnoses, which is really, that's where my research interests are.
Thank you for sharing information about the Berger Consortium with us. Would those participants in their locations be places where families who are close to them, such as the University of Washington, could make connections to have testing and to connect with someone such as yourself to consult with?
Good question. So the Berger Consortium has five main centers. They each have slightly different ways in which they recruit people to their programs. University of Washington, they do a lot of cohort-based analysis. So they work with like research groups that have collected large groups of participants, and they don't necessarily directly enroll families.
I see.
So, I mean, our site, we directly enroll families and will directly enroll families anywhere in the country.
Great.
I mean, there are definitely great researchers at University of Washington, and I'm happy to, if families are interested, I'm happy to make an introduction to people I know there. I mean, their clinical team is bar none very top. They have a top genetics program in the country, and I would be happy to introduce people.
Thank you. Any other questions from our families out there?
Yep. We've still got time, so
Yeah.
that's why we'll make sure we get everybody's questions answered.
Nope.
Such a great service you're providing.
I could start doing my genetic stand-up routine if anybody wants it, but
There you go.
That would be great. Well, in addition to all the wonderful work you're doing now and that you've done over the years, we're just so grateful and just always wonderful to hear information. I remember first hearing my first exposure to all of this at the conference in 2022. And certainly this update has just been extremely beneficial. And we thank you so much for all the great work you're doing. We really appreciate having you here this morning.
I mean, I think the most important point I would like to have gotten across today, though, is that I personally feel that a genetic diagnosis helps scaffold care, helps clarify recurrence risk. I mean, it's not, I mean, for holoprosencephaly, especially an isolated holoprosencephaly, probably is not going to change too much. But that being said, it honestly, it makes those medical notes that the doctors just copy from clinician to visit tell a slightly different story.
Right.
There's such complexity involved. Is there ever, do you think, just personally, that any one area could lead to findings that would make a difference? And, it just from this today, there's just so much complexity. Is there a path that you see going down that might get us to a place that we've never been before?
So, it's really, if you look at the last few years of development of genetically targeted therapies, I've been like shocked at what has come out of it, in all fairness. And there are things that are coming into clinics now that I would have called was science fiction a few years ago and now seem like science fact.
Wow.
And I mean, like, let's take another rare neurodevelopmental disorder. Take Angelman syndrome, for example. Historically, we would tell families of Angelman syndrome, your child is never going to be able to talk. They're going to make very little developmental progress. But now there's a molecularly targeted therapy for these children, and a lot of them are learning how to talk despite this. It's incredible what understanding the molecular mechanism of the disorder has allowed. Now, that being said, it's a little bit more challenging than something like Holoprosencephaly, where it's a structural developmental anomaly at the end of the day. I mean, it's hard for me to envision a treatment that's going to help a brain that didn't fully split the rest of the way after the there's the old analogy of baking a cake, and you can't throw the egg into the cake mix after you hard boiled it. But I mean, trust me, I have a neighbor who tried. She's not a very good baker. But that being said, I mean, I don't want to let the limitations of my imagination hinder where the field is going, because literally I would have said the same thing to the Angelman community a few years ago, and it's incredible how far they've come. And I mean, and honestly, a large part of that has been through the advocacy of their family groups and their community groups, and getting the research community to do what they needed to have done. And that being said, also there's the whole idea of, look, even if we don't find a major treatment, there may be ways of really improving quality of life in specific ways. I know a lot of your children are on seizure medications and having lots of seizures, and we may find better ways to specifically target and control seizures for specific genetic etiologies. These are we may be able to, I mean, the Mocha Lab has published a thing about certain type of liver disease at one point and its association with certain genes. We may be able to find ways of improving that. So that's really the goal here. I mean, I believe targeted treatment starts with getting a targeted diagnosis, and that's where I come in. That's where I come in at the diagnostic side, but we need someone to pick up the treatment.
Well, that's great to know. Then my takeaway from what you've just shared is that, we can continue to have hope and to look for these things that, as you said, science fiction yesterday that becomes science fact. So it's very exciting and so very grateful for the work that you're doing. And it's wonderful.
Elon
I
Musk
think there's
brain
one
chip.
other question.
I put it on the chat.
Oh, okay.
Yeah.
Here's the question.
Yeah, Elon Musk brain chips. Any thoughts on that? I'd have to ask ChatGPT what they think about that.
Yeah.
No, I mean, look, I don't want to let the limitations of my own imagination and who knows what the future is going to bring. I mean, that, I did see the news about the recent brain chip that he has for somebody the paraplegic who can control his chair with his brain chip now, right? I mean, it's an amazing world, and I have not going to let the limitations of my own imagination again. So I'm not an expert on that at all.
Oh, so do you ever think there's well, and this may be kind of a loaded question, but be able to reverse HPE?
I mean, reverse. I mean, what do you mean by reverse, right? I mean,
Yeah, that's what
Here.
it's kind of because I think somebody, had talked yesterday about, a family had all their embryos tested or whatever and found the one that didn't have, any genetic issues. And so I think, okay, well, that's, that's more of like being able to selectively say, okay, this is how to avoid HPE if they have that genetic makeup. But yeah, it was just a question that somebody had asked yesterday about reversing it. So I didn't know if that's even, it's kind of a weird question to ask to be able to answer, but
I mean, again, I'm going to again put that into the, I'm not going to let the limitations of my own imagination
yeah,
go here. I mean, I would refer to the cake analogy that it's, once you bake a cake, it's very hard to unbake it.
right.
Uh, but that being said, I mean, look, this conference is about hope, and I'm not gonna say anything that is.
Yeah. Yeah. Agreed.
But I mean, I would say that would be in the much more distant science fiction than the closer science fiction.
Well, again, thank you so very much.
Rachel had a question.
Rachel asked about brain plasticity. I mean, it's not about plasticity itself. I mean, brains do rewire all the time. I don't think that this is more, HP is mostly a thing about brain patterning, about how the different parts of the brain are connected relative to each other and how they form relative to each other. I would argue that it's that the physical therapy and the lack of improvement is not necessarily a plasticity issue, but a patterning issue of how the brain is shaped and formed. But I would, as I tell everybody, work with your physical therapist, work with your occupational therapist, work with your speech therapist, because no matter what the potential of your child is, doing optimal therapies is the best way to help them reach their maximum potential, whatever that potential is. And I mean, even if they're having a slow start now, it doesn't mean they are not going to continue to show a leap later on. But so, I mean, I always recommend people to keep working with therapies and not to give up on them because they're the best ways to make those improvements. I know 22, it's hard. We'll talk, Rachel.
We might have one more question.
So Lily's verbal. Okay.
Excellent.
Yes.
Yeah, I mean,
Very.
Very verbal. Great.
I look forward to chatting with her.
That's wonderful.
Cusses
Oh,
like
perfect.
a sailor.
She'll fit right in our clinic.
That's okay. I had somebody the other day tell me that they were in church and their son repeats everything that he hears. And so apparently something the minister was talking or something, and they were kind of all together, and her son just was like, I guess I can just say it here, it doesn't matter because we're doing it in context of it, but he looks at the preacher and goes, well, shit happens.
Okay, now you just have to bleep that before you post this video anywhere.
I was like, that's awesome.
Oh my.
Oh wow. Seth, you're going to have a lot to talk about.
Bring chips.
I mean, yeah. There's actually some interesting studies about the use of cannabinoids in neurite outgrowth, actually. So
Wow.
Okay.
anyway, what time is your next speaker coming on? Do you have a a break built in now?
11:45.
Okay.
So,
Yes.
You're covered.
So
Thank
thank-
you for joining on COVID.
we're excited for Kristen to get here so I can start. So she can start cursing. So.
Yeah. Well, again, thank you so much for everything that you're doing and for sharing with us this morning, Seth. We are just thrilled that you could be here again, and we will definitely be sharing all of the slides and information that for those who weren't able to stay with us or be on. So we're happy to have that. And again, thank you, and thank all of our people who have joined us for this presentation this morning.
It seems like next time you got to put me and Dr. Krushka back to back and we'll average out.
Yeah,
go.
that sounds great.
There you go.
Wonderful idea. Thank you. We'll let you go now. Have a
All
great
right.
rest of your day.
Talk to you soon.
Thank
Yeah.
you all for having me. I really appreciate all the work that your organization does. It's such a really wonderful organization.
Yep. And we're gonna keep you in the loop. We'll try to get you more involved. We're gonna do some podcasts and things with folks. So I'd love to have you on for one of those too.
Yeah.
Okay, no, that would be fun.
Yeah. All right.
Great. Take care.
Okay.
Well, we're back, and again in between that we're just ahead of our next presentation, which is Janice Scott, wonderful person who has tons of experience as a clinical dietitian, and this session with her today is going to be open and free for all of you to share and just Q&A and dialogue with her. I think one of the wonderful things about our community is that you all have your own lived experience that you share and things that you know you're doing that works really well. To be able to talk and talk with someone who brings her expertise and then combined with your own experiences will be great.
And Janice actually is on. She's been on for a little bit, so
great.
we're probably gonna start with her a little bit earlier because unfortunately yesterday we had a couple technical glitches like I talked about earlier, and so her presentation yesterday got cut a little bit short, and so maybe we can kind of make up for it today by giving her a little more time today, and then hopefully we don't have that issue. And this is her last week at the Scottish Rite Hospital, so I'm sad that it's her last week there, but I'm hoping. I think Janice made a comment one time that she wouldn't leave us as far as Families for Hope goes, and so we're hoping that maybe we can figure out a way to keep Janice involved with what we're doing and the information that she has and what she might be able to share with us in the future.
There you are. Welcome.
Thank you. Thank you so much. And I do plan on, even though I'm retiring from Scottish Rite, I do plan to stay active in the nutrition community and to stay active with the Families for Hope. I have learned so much from all of you, from the professionals to the parents who are professionals at HPE, and it really does help me treat families, to understand the families that I've worked with directly are wonderfully open about saying, "Oh, that didn't work. Let's try something else." So so I was trying to hang around till you change your phone number, and I'll have to hide out. You'll have to hide out from me. So anyway, again, as Steve and Susan said, I want to open this up to questions. I did have a question yesterday that came to me just by email to talk a little bit about oral feeding. But first of all, I'm going to let you, if you want to send some questions, I can do that. And in the meantime, I thought, let me just prime the pump by talking a little bit about oral feeding and kind of some of your concerns there. So I have a quick little slide to show kind of my goal as a dietitian is to I have to centralize my goals, and I have to say, what do I want to accomplish here? Again, always the goals of good nutrition to provide sufficient calories and protein and vitamins, all of that's important, and to support adequate growth. We don't always have a good definition of adequate growth in HPE or any of the related brain malformations, but that doesn't mean we shouldn't work towards something. But at the same time, as we know that about 75% of the families, their children end up with a feeding tube. So try and find a balance between what is possible to stay with by mouth and what we should be filling in with the tube feedings. And again, like the last thing I said here is we want to feed in a method that it can be delivered in a reasonable time frame, because there's so much more to life than just feeding. So sometimes that's the benefit of a feeding tube is, yes, you can meet your nutrition needs, but are you feeding 12 hours a day? Are you going from little meal to little meal to little meal? And then your day is done and there's no opportunities for anything else. And so for me, that's when your use of a feeding tube can kind of concentrate those calories into a smaller time frame, and then also provide you with the opportunity to do other things. So, I'm in the wrong direction. And again, so we talked about, again, what part of the question that I got was, well, what's reasonable for weight gain? Oh, and that's a hard question. Just like the previous speaker said, what we thought was reasonable before, what we thought was impossible is now possible. But so when you're an infant, or when your child's an infant, you can have a weight gain of 30 grams a day so that you are gaining very, very rapidly. But by the first year, that really slows down by about 2/3. And then from then on, your average weight gain up until maturity is about 5 to 6 grams per day. Again, these are really rough numbers. So that's where we kind of start with that. Again, I'm always looking at what are your goals as a parent? What do you want? What can I help facilitate for you when we're designing a feeding plan, a nutrition plan? Because again, as I said yesterday, I have all these numbers in my head and in my resources, and I say, okay, I want them to gain 15 grams a day, and we're going to shoot to achieve the 3rd percentile weight for age on our growth chart. All of that's real technical, but what does that mean to the quality of life, of your quality of life, your child's quality of life? Do they enjoy eating by mouth? Do they, is it a struggle? Is it for your family? Again, are you feeding 12 hours a day and it's just taking up everybody's time and not exactly fun? So my ideas or my thoughts are to find out from you, and any dietitian, physician, whoever you work with to design your feeding plan, or for yourself, if you say, I got this handle, think about what else there is in life that you want to have happen. So again, you want to design around nutrient needs, but also quality of life there. So talk a little bit about dysphagia, and I'm going to see if I can share my screen without turning off my camera. Just because I have this little slide about, there we go. Pop up here, about dysphagia and about swallowing problems, and again, as I always say, we're one giant tube from the top to the bottom. And then all of the specialized things in between there make breathing and swallowing and digestion possible throughout there. So this is just a little picture, a little pictogram of the early part of the swallow. And you can see there's a lot of complicated structures, the epiglottis and the trachea and the esophagus, and they're all kind of squished in there together. So when we're looking at safe feeding, we want to make sure that we have adequate coordination, that the child is able to take food, swallow it into the stomach for digestion without getting in their lungs. The lungs just don't want food, of course. And then that can cause congestion, can lead to aspiration, can lead to pneumonia. And again, it's just a generally unpleasant experience if that food is going in your airway, because we're really designed to cough it out. That's what a cough is for, to kind of keep that airway clear. So any rate, so I wanted just to kind of review again. I know we talked about this a little earlier, but does your child need a swallowing eval? When you're designing your plan, I would say we would start there. So again, does a meal take more than 30 minutes? Is it stressful? Is your child fighting you? Are they coughing? Are they choking? What do we need to do? Do they have frequent upper respiratory infections? And then are you having trouble with weight gain? Is it just kind of stalled out there? So I would say any of the questions, answers to those questions would be yes, then yes, let's look at getting a swallowing eval. So again, I'm not going to go through this because I know lots of you already know that, but these are the things that your physician or your therapist would look for: the lack of skills, the incoordination in getting feeding done, what kind of anatomical problems. Lots of times with a cleft lip or a palate, that doesn't completely rule out oral feedings, but there's lots of adaptations. There's some equipment, and I'm not a speech therapist, but there is lots of things that can happen or that we can put in place to kind of make some feeding possible. And again, you have lots of respiratory issues. Is it feeding just not fun? And my idea is to make feeding fun all the time. And then reflux is another issue. And so you can see that the structures get bigger, but that doesn't always make for better feeding. So we want to look at that. And that might be another reason. If you had a swallow eval and you put some strategies in place for oral feeding at, say, 18 months, and then come around 5 or 6, or even a little bit later when the kids go through a growth spurt, then all of a sudden you're having all sorts of feeding issues again. Then maybe it's time for another swallow eval, again, to see what these structures, what the coordination of that is, because that takes, it takes the brain a lot of coordination, a lot of signals to say, close the lips, squish the tongue up against the roof of the mouth, push the food to the back, push it down, but the epiglottis has to cover the airway to make sure it doesn't go in the airway, and then the swallow has to happen. So there's lots of coordination there. And again, in a bigger environment, it takes more coordination than in an infant environment. So if you had a good swallow study at 18 months, but you're starting to see those same questions again, feeding's extended, lots of respiratory stuff, food's not, meal times are not fun, get another swallow eval that doesn't say that you can't do feeds again, but it might say we need to change textures, we need to do something new. Okay, so again, we're looking at consistency changes, cup changes, specialized equipment. I know Heather Roberts is talking after me this afternoon, and she is the queen of adaptive equipment. She knows so much about all of that. And so if you have questions about what equipment and what kind of cups and what kind of adaptive equipment, like the spoon holders and that sort of stuff, she will be your best one. I rely on her a lot here. So again, we want to find safe textures. And if you've had a swallow study, all of these little terms are more familiar to you. But I will tell you what I have found is that I used to, when we talk about liquid consistency, I thought you go honey thick or you go home. You just don't do anything more than that. But I have found that sometimes that change to slightly thicker, just slowing it down by milliseconds, allows a child to swallow safely, as opposed to thin, like water, juice, Pedialyte, that sort of stuff. It just gets there too fast, and all the coordination can't happen. Now, honey, again, you might need, in the Swaddle study would tell you that you might need a thicker food, or you might a liquid. And so like if nectar or half nectar would be like a Pediasure, or the texture of, like a latte or a protein shake or something like that. Whereas honey, the next step up, or nectar, or slightly thick, that would be like heavy cream, or a Brahms milkshake, or a McDonald's milkshake. A Wendy's Frosty is about honey texture. And again, you could say, well, my kid does great with Pediasure, or great when we do a milkshake. But when we give juice, they're sputtering, they're coughing, they're turning away. And that just says, okay, we're not having all of the signals that we need in place for them to get this swallow safely. And then again, sometimes they'll say pudding liquids. Here's my prejudice, and my whole speech, I've like given you my own view on this, but pudding thick liquids, you can't get those out of a cup unless you have a very specialized cup. Usually those need to be fed by a spoon. And at Scottish Rite, our mantra, or our sense, is that if you're moving from pudding thick liquids, or they're recommending pudding thick, then probably time for a supplemental feeding tube, and then do your liquids by the tube, and then whatever solid consistencies you can off a spoon. Because that's too hard. It's too cumbersome. Takes a very, very long time to meet fluid needs by the half teaspoons, if that's how you're doing it. Doesn't mean that you can't do some by mouth, but you need to be watching that. All right, so then we can talk a little bit about thickeners. If you're in the thickener environment, you've seen all of that. You probably know as well as I do, the FDA has taken Simply Thick and made it approved only for older children. Some families have lost the ability to use Simply Thick over time, simply because their vendors are saying, we can't give it to you because your child's not old enough. Again, depends on your vendor, depends on your DME and your physician, whether or not they'll write for that. So we kind of went through that. Modified food textures. Again, your speech therapist may say, I want a smooth puree. I want a ground food. That would be like the bottom picture. It's probably best in a blender, like a little bullet blender, to kind of chop it up and add some gravy to that. Or maybe they can manage textures that they only need to chew for 2 or 3 bites, and then they're good. So, but again, all the goal, we go back to the goal of, is it reasonable? Is it a reasonable time frame? And are we meeting those goals? And where are we looking at growth? And that's where, when I talked yesterday about assessing growth, what are we looking at? Does it seem reasonable? Does it seem appropriate? So, anyway, do we have any questions yet? A little bit.
Okay.
Oh, pancreatitis. Oh, yes. My sense is that I take my direction if I have a patient that has pancreatitis. Oh, I would, yeah. Jessica said we have an endocrinologist and a GI person to say, and they will kind of inform me about, okay, we want you to do the diet this way. 40 years ago, the advice for pancreatitis was always a super low fat diet, made it hard to meet nutrition needs, whether you were a child or an adult. And they really are kind of coming back and saying, okay, well, what if we did a different kind of fat? Sometimes some endocrinologists saying, yes, an MCT predominant formula is okay. Some are still saying super low fat, add all those carbs. Sometimes, and that's really hard to plan, especially if your child has relatively high calorie needs. It's hard to do, but again, the endocrinologist is going to tell me how they would like me to direct the child's nutrition. And then the GI will help me figure out how to get all that in there to say, yes, you can do this. You want to do a peptide-based formula. You want to do an elemental formula with specialized calorie boosters, that sort of stuff. But you're right. The idea is give the pancreas a break, get the inflammation down, and try and figure out. Now, again, it's been a little bit of time since I've worked directly with the pancreatitis because our particular endocrinologists have their own dietitians, and I just take my direction from her. So she tells me what she wants me to do in terms of supporting normal stuff. Yeah, so it is tough, and it's hard to keep a weight up. If your child has pancreatitis, I think my friend and the dietitian at the endocrinologist would agree that you're probably going to see some weight loss, and hang in there, because once the pancreatitis resolves, you'll be in better shape. And you'll be able to go back and get those calories in, or you might find a good formula that works for you. And you're right. Yes, there's so much pancreatic damage that it's important. It's important to get a handle on that. It's important, I would say, and I think that lots of the right pediatricians, if you find the right PCPs, that when your child starts having issues, I know that our physicians here or over at Children's Medical Center, which is our big general medical center here in Dallas, they listen well. They listen well to parents. And if you say, oh, my child is having a terrible pain when they eat, well, they're probably going to listen. They're not going to say, oh, it's gas, or oh, it's constipation, and here's some Miralax, or here's something. I really feel like the right physicians will listen. And again, because they understand that you guys are well informed, and that you're also you understand the medical ramifications. Okay. Okay, so let me clarify this question. What concerns, so the doctor has recommended, so she has diabetes insipidus and her sodiums go very, very high. Is that the question, or is that what you're asking? And how to keep her fed, keep her sodium intake low. Okay, so does she have a feeding tube? That would be my first question. Okay.
Yes.
Okay. So yeah, that's where your dietitian can look at the sodium that's in formulas. And so just as kind of in the broad spectrum, if she can manage a whole protein, regular carbohydrates, regular spread of the types of fats, there you go. That's very good. So you can add, so Pediasure, just general, it happens to be the lowest sodium of all of the commercial tube feeding formulas out there. So now when you're trying to do that and you're trying to do a formula, if you say you give her about 194 milligrams of sodium a day, that's just barely getting her 2 cans of Pediasure a day, not much. And so that's tough. Now you can add things that do not have sodium in them, would be things like the Duocal has a very, very low sodium profile. Even regular corn oil or safflower oil, or some of those just olive oil, those standard oils. And you can change the really what I call the nutrient profile. We have a standard, most formulas are about 7 to 10% protein, and then about 35 to 42% fat, and then the rest is carbohydrate. So you can add, like if you're limited to 2 cans, for example, 2 cans of Pediasure to keep your sodium down, but you really need 700 calories a day. So just like you have blended food that you're choosing with the to be a low sodium profile, and then you can add those modulars. to her intake, you know, like a little added unsalted butter, if she's doing blended vegetables or blended potatoes, something like that. So again, you are always kind of looking at every label. I'm sure you look at every label and every nutrient. And but yeah, so the low sodium. So no, I feel like the low sodium, some kids need more sodium. And it always just kind of flies in my dietitian's face to say, we're going to add 1/8 of a teaspoon of salt to your child's tube feeding formula. And because there are some children whose kidneys, now again, the sodium absorption, reabsorption, excretion is again, particularly in HPE, is really driven by the brain, by the hormones in the brain. Whereas there are some types of diabetes insipidus that are controlled by the nephrons in the kidneys, the little filter manufacturing, the little filter things in the kidneys. And sometimes they're super good at washing out all the sodium or retaining it, and it stays in the system too long. For the most part, again, you guys are all answering your own questions here. That's great. Yeah, that's the, yeah, so you have to say, and that's where checking sodium, I understand from another parent, there is now a home test that you can test sodium. You're not having to drive in to the hospital or to the doctor's office on a weekly basis to get a serum sodium drawn. And I think, oh gosh, that's the best thing ever. And so yeah, so you, Jessica, like you said, you add or you hold water depending on her urine output, and that's again, you want to make sure that concentration is not overly, you know, that she's not too dry and that she's not over, or that she's overhydrated. And again, I don't have good answers. I don't pretend like I do, because what I tend to do is, again, take my direction from that endocrinologist. We have a great endocrinologist here. My kids go over there. I can tell him, okay, this is my formula blend. It's going to provide 622 milligrams of sodium a day. Do you want more water? Do you want less salt? Do you want me to redesign the formula? And so we have this great working relationship. And that's kind of where we go. Again, I try not to get in the sodium and the fluid business for kids with DI, because I need somebody smarter than me to help direct that and to know what those hormones are and such. Yes. And again, I would be very interested. I don't have a brand name on the home sodium checking. My understanding, it's like a glucometer, but again, if somebody has something, and I will try and research something in between our sessions today to see if I can get a handle on that and give you a brand name. So Ms. Hilliard or Mr. Hilliard, do you mind sharing what formula you're using? So again, a blend of quite a few things. So you're making a home blend, which is great. I brought some formulas just in case we ended up talking about formulas, so I could look at labels and embarrass myself by needing longer arms to read the sodium. But if I'm looking at the sodium here in the Kate Farms, so this is the pediatric peptide, the 1.5, and it has 200 milligrams of sodium. Whereas and the Pediasure 1.5 has, I think, 120. Oh, it has 90. So this has 90. So that's even lower than the regular Pediasure when you're looking at calories or sodium, milligrams of sodium by calories provided or the energy provided. Oh, it's a great, I'm going to have to get some more information about that. So using Kate Farms pediatric peptide, love that formula, and the Real Foods blend. Now, that is a good one to mention the real food blend. Traditionally, one of the things when it first came out, one of our problems with real foods was it was too low in sodium. And we were, and our other kids in the cerebral palsy kids or other tube feeding kids, we were having to add salt to the real foods to get the sodium up because it was extraordinarily low sodium. But you're right, real foods blend would be a great one that you would be able to give more calories and not have to worry about so much about the sodium. So speaking of blended formulas, I would love to know if anyone is using the Nestle, the home blended formula builder from Nestle Nutrition. Have you seen that? Has anyone seen it? We use it. I use it a little bit here, not as much as my other dietitian, who is kind of an expert in that goes to a clinic that does lots of home blended, and she's loving it. She builds all kinds of things. You can do a combination of commercial formulas. So if you wanted some like complete pediatric formula, and then you wanted to add your own things, and then you kind of get your own mix, and it analyzes it for nutrition. And it allows you, I've not used it a lot, again, mostly because the last couple of years my practice has gone a little bit different. And so for the Nestle, so it's Nestle Nutrition. I think it's the complete, I'm sorry, I wrote it down in the other office because I was talking to Paul about it. Let me text her and get the name of the
iStat. Well, that's why I wondered if it was still an iStat machine. I used to use those when I worked in the clinical setting, but I didn't know if iStat actually had that. So, okay.
Did sodium. And that's good to know.
Yeah. It did everything else. It even talked to me. So I figured it got to do sodium. Well, you're waiting.
But I think how nice that would be to not have to go all the time, particularly when you're finding you've had an illness or you've had something else going on. And then your biggest issue then after they recover from the illness is that you have to start watching for the sodium and have those problems there. So that would be nice to check. So
I'd be curious as if anybody that's on our call today, if their kids are eating by mouth or strictly by a G tube or maybe a combination of both. I know Sammy, he was G tube, but we did the stuff by mouth just for pleasure. Him, because he can swallow little bits of stuff, but he never could really pass that swallow study. But I'd just be curious if any folks on here are kind of doing a combination or if people are actually like making their own, if they're eating by mouth, if they're doing it, making their own food.
That's the blended. She said blended. That's what she's talking about.
That's what blended. Okay.
Yeah. But so let me make myself really old here. When I started in practice, there were no commercial formulas. And so we made all of the formulas. We designed them when I first started at the hospital here. Is I made all of our own formulas. That was my job. And so then when Pediasure was, actually Osmolite was the very first ever commercial formula. And then they came out with pediatric brands. And now I look at the formularies that are available and it's amazing. Lots of specialty products, lots of variety. And now we're going back to making your own. And so it's nice to have that and as an option. And again, it does give you a lot of variety. I will tell you from experience, it's a lot of work. Your dietitian can help design one or they go to, I'm waiting. Paula, it says she sent me a message. She's looking up what the actual website is for me on the complete. So it's called the complete blenderized tube feeding. I think that's what it comes up under Nestle Nutrition. And I'll try and get that actual where she sends me the actual website. I don't want to take a chance of turning myself off here again, but any rate, oh yes, and so I'm very supportive of whatever small amount of oral feeding, even if it's one bite of the best lasagna you ever made. It's cheesecake. Everybody should have cheesecake, even on non-special occasions.
Yeah.
And honestly, when you're looking at calorie boosters, as a term, and we get real technical as dietitians, and we say, you can use MCT oil, or you can use avocado oil, and you can use this, and you can add that. And then, like if you go back to real food, well, you can use cheesecake. You could use, like Alfredo sauce. If you're making a meal and you want to just power pack it, what's worse than Alfredo sauce? Especially if you know somebody that makes it on their own, how much butter is in there. So, I try and get my head out of being technical and saying this many grams of fat and use olive oil or something like that. And then go back to, okay, what's a good food that you're having that you like to have that you could do there? So again, looking at the textures that they can manage.
This probably sounds like a dumb question, but with the thickeners that they have, is there a way to thicken things without using those?
There really is. Again, kind of going back to the days of when we didn't have specialty products. There was a recipe for boiling cornstarch. And again, this really goes back, but you could boil cornstarch as if you were making an unflavored gravy. And then you would stir it into whatever liquid, like just as you had just made that thickener, and then you would stir that into whatever liquid you were hoping to thicken. Now, I really can't vouch for the actual taste of it. The newer products are tasteless, but I do know that I learned how to make essentially a cornstarch slurry to thicken liquids. And actually, the recipe, now that I think about it, came out of the Mayo Clinic diet manual from 1935, which we had in the office when I did not start in 1935. Thank you. we had our when I came here, and we had a library of little books, and we had the 1935 Mayo Clinic diet manual. But I just remember that was in there. And then we got specialty products in, and we all forgot about making cornstarch slurries in that. And then, but you also can use things like if you were making, say you were making a soup, you could use instant potato flakes. Those thicken like crazy. I've made some concrete in my time. Whipping potatoes into a blend. And then just even pureeing vegetables, like baby food green beans tend to thicken over time. And that's, you can use that in your mix if you make them blend, or if you made a dinner and it's concrete, and then you can use like a baby food green bean, or if you're at a restaurant and you got your mashed potatoes, you got your meal, and then it's too thick. If you have a jar of baby food green beans in there, you can stir it in, and that kind of helps bring the consistency up. And I don't know exactly how that ever came about. Probably someone, a parent going, oh, what do I have here? I can open up and dump in to make my blend a little bit thicker to be able to tolerate. So what else? What should I tell parents going forward? What's your advice for feeding? What do you think about a combination of G-tubes and oral feeding? Do you think it's worth the work, or do you just give a small amount of oral feeding? And what would you want your dietitian to do? Like, it's your turn to teach me. What should I do?
Unless they had a question she put on here, there's if you had any thoughts on avoiding flavors or coloring that's added to liquid medications for children. Like with Sammy, red dye number 40 was a big one that he'd have more seizures. And then, or you give him something and goes in his G tube, and then next thing you know, you're freaking out because it's coming out in his diaper.
Right. Yes.
So, but they
Yeah,
also,
the-
pharmacies,
Yeah.
The pharmacies use them in the suspensions they make. And so we're just
Yeah, and I think you have to be firm with them to get, when I was working primarily with patients on the ketogenic diet, to try and get medications for, even for the G tubes, even if you specified for G tubes, then, the pharmacies and the outside, Walgreens, CVS, the private pharmacies, they always wanted to flavor. They wanted to use the syrup is called Serpalta, and they always wanted to use grape Serpalta or cherry Serpalta, but it's too much carbohydrate for a ketogenic patient and for kids that are sensitive to artificial flavors and artificial colors. You can still get the medication. They can still prepare the medication, but without those. And I think it's thinking outside the box.
It just said for future topics, they're desperately seeking help on making home blends for a kiddo with DI. The parents in the blending Facebook group I'm in usually say blend them whatever you're eating, and it's not as easy to do that when you're trying to monitor the sodium and the volume intake.
Absolutely. And I think that's where the Nestle home blended formula, or the blended formula maker. I didn't get a response back from Paula. She may have had to step away. Yes, so that will help you. And then I've even built, before the Nestle home blend thing, I've used MyFitnessPal because it does have a good information on sodium, or a newer product called my Chronometer. It's Chronometer, so chronometer, essentially. And that's been a good builder when I'm looking at particular nutrients. Like if I need a high iron formula, I need that, or you start looking stuff up. But yeah, I have to say blending, I know lots of places will say blend what you're having. So you shouldn't blend leftovers because you want fresh food that is just there. You can't say, oh gosh, we have pot roast left from 2 nights ago, let me blend that. Because you need a balance. You and I eat a whole variety of foods. Not all of that is susceptible or amenable to blending. And so I like to build some varieties. Again, when I was blending formulas exclusively, we'd have a red day, we'd have a green day, we'd have an orange day, we'd have a white day. And then, so I would choose my vegetables. For example, baby food carrots or steamed blended carrots. Then some days I do beets. I always thought the beet formula was the most beautiful. Not everybody liked it because if you vomited it, it was pretty permanent in terms of the color. Not a popular blend. But again, I felt like you're giving a variety of foods, and that's the goal behind a blended formula, is to offer a bigger variety of tastes and a bigger variety of nutrients across the board. I will say, I read a new paper I think it's from 2021, so it's not exactly new, but talking about kids with reflux did better on a blended formula because it was heavier. Now, I've not always, I don't say that I have tested that, but that was kind of there. I think it was the University of Alabama that did that paper and looked at doing home blended formulas or partially home blended formulas. So a thicker formula had less reflux if your child was susceptible to reflux. Again, I have not tested it, but it would be interesting to try out, or a thicker formula if you're using Kate Farms 1.5 and that's the best formula for you. Then possibly thickening it a little bit and seeing if the reflux is better, if there's less susceptibility to that. So I do have, so we were just talking about this and I realized this is still on my desk. So again, and this is not, certainly not an endorsement or something, but I've had a lot of families ask about the Kate Farms pediatric blended meals that come in the little pouches. I don't know if you can see that. They're interesting. They are in Texas, at least at this point. You can get them in the same prescription that you get your regular Kate Farms or your regular Pediasure, because they're coded the same in terms of Medicaid funding and the insurances that they cover it. It's coded the same as a regular Pediasure formula. You have to find if your vendors can, and they are so new to the market, but there's 4 or 5 different flavors, which, and I anticipate, this is Kate Farms, you know, and they tend to be the leader of new innovations, but I imagine it won't be long before Nestle and Abbott formulas, the other big manufacturers, have something similar. Again, there's a lot of novelty to a formula in a pouch. It's the same thickness as a regular formula. It just does, this one is butternut squash, carrots, and buckwheat. So I kind of feel like this is a combination between Real Foods blend, you know, which is super thick, Real Foods blend and regular Kate Farms. So something in there, but they're interesting. Families have begun requesting it. Not every vendor that I work with are carrying it, but it's been interesting. I have a family that just feels like it offers more variety, that speech therapy is going better with a different variety of foods. And this is a way to not have to blend your own, but at the same time, be able to offer some variety.
The industry went through a shortage of formulas. I'm not sure you can hear me. Let me see here.
Yes, I can hear you. Yes.
Oh,
yes.
good.
Oh,
Okay, good.
yes.
Is that better now?
It is better. It is better. There are still, now, even just this morning before I came on, we were struggling with one of the Nestle formulas. And again, the farther outside their standard mainstream formulas, you know, the Nestle, say, oh gosh, I'm blocking on the name of the Nestle standard formulas, but you know, like the regular complete modified formula. But if you want the plant-based or you want the organic ones, those are the ones that lately are harder to come by when I'm trying to order for the hospital. But when there was that huge shortage for Abbott, and that would have been, gosh, almost 3 years ago now, that was a scramble to try and find, to look at, okay, what's your child on and what's the next reasonable alternative? But really what I found is it just pushed the shortages to the next manufacturer. So Abbott took Pediasure offline in order to redo their manufacturing plant. And then all of a sudden the Complete was out of stock. Then the Complete was out of stock and Abbott wasn't up to stock. And then the Kate Farms was out of stock. And then Kate Farms had a recall, and then so it just pushed it around. It's better, except for again, I think that what I'm finding are the ones that are outside the mainstream. So like maybe right now they have 1 million of the pediatric blended meals, which I like. But then they don't have any Complete this week when I tried to order. So it's just moving around, but I do think that I know Abbott in particular has scrambled to get their market share back and to make sure there's no shortages.
So do we really think that manufacturers have gotten their act together, or do you see that could happen again? What do we need to do?
Hopefully the hard lessons learned by Abbott, who I think just thought, we've got this. We are the giant monster in the market. Nothing can ever happen to us. And really the product or the problem formula was with a particular infant powdered formula. But then as they said, oh, we've got, you know, FDA or whoever made them change, they took a hard look at every step of every product, even to the adult world, every step that they had. And they had to take plants down in Columbus, Ohio, across, I think there's one in like Tennessee. I can't remember all of the details on that, but they were scrambling and they lost market share. I was hesitant 2 years ago when I came back to Scottish Rite. I was hesitant to use any of that. And I would say, okay, I know Kate Farms is here. And then Kate Farms had their recall. But I'm hoping they figured it out. And then we have variety, and we do know that there are other products. You know, we'll push it around if you ever have a question, and even, you know, you can always email me and say, I cannot get complete pediatric right now. What's a reasonable alternative? And I have a little spreadsheet that we built that say nutrient wise, protein source wise, fat source wise, what's the most similar to whatever's out of stock. And so.
Janice, a little bit ago, you mentioned reading labels, the importance of, you know, always reading labels. Is there anything in the food industry today that you think, just by and large, whether it's additives or anything that families or that we as consumers should be thinking about advocating for their change?
Well, I think that manufacturers are slow to respond, but I think that the market forces are coming back to say, you know what, I'm not going to buy this because the whole end of your thing is full of preservatives, which are not necessarily a bad thing. You know, we need to be able to have that if we want the variety of food that we like to eat, and if we want our Wonder Bread to stay fresh for 2 weeks at a time, we have to live with some additives. Now, most of those additives, and again, I would say 100% of the additives are really proven to be safe for the average person. I think what manufacturers are coming back to say is, okay, so can I make a version that it doesn't have quite as much, or is there a safer one? And they're responding to that. So yeah, so I think we're getting something better, but again, you know, if you have a loaf of bread, like me, I had a loaf of bread that got shoved to the on the top of the microwave, got shoved to the back. And I just got out the new loaf and I was using that, and then I was cleaning and I went, oh, well, this expired in May, but it's still soft. You know? I just wonder what else is in that bread to make it soft. Because if you buy like an organic bread or you buy something like that, you need to be using it. So I think my bigger concern, rather than what is in manufactured products, you know, the things that have to go through FDA approval and have some regulatory oversight, are supplements that are marketed. I guess if you get on my little soapbox, supplements that are marketed to special needs families as having some actual benefit. Those things are not approved, and they scare me. They scare me to say, you don't have a USDA label, you don't have an NSP, which is the pharmaceutical approval label. You have no idea what's in there. You have no idea what additives could be in there. Even if you kind of truly believe that it is something beneficial, what else is in there? And how much money am I spending? Nancy and I worked with a neurologist, Dr. Delgado. Some of you knew him from before, and he had me look at a product that someone was pushing him hard to prescribe for special needs families. And we went back and we looked at what was in there, and it really turned out to be powdered milk. If you look at the label, powdered milk and cocoa powder and sugar. And that's all that was in there. And then maybe half the equivalent of half of a multivitamin. But it was a neuro something improver and marketed very, very heavily for very, very much money. And when we looked at it, it was nothing. There was no benefit. There was nothing in there. And I always worry about that. And I see, and honestly, my daughter would kill me if I told her this, but she's an adult. She's an adult. And she's always looking on the internet. Facebook is always bringing something now on the algorithms because she looked at maybe mushroom coffee or colostrum supplements or something awful. And she goes, well, what about this? I'm going, no, just no,
Okay.
don't trust them. You know, I'm not gonna drink or smoke a mushroom. And, you know, I'm worried about that. But so you have to it's just buyer beware, because the marketing is very, very persuasive to say that I can make you smarter, I can make you more energetic, I can get you through your 3 o'clock slump. Here, drink my coffee, my mushroom coffee. Now, is mushroom coffee probably, I don't know. I don't know enough about that. And I don't know, and they're not forthcoming with their added ingredients. Specialty, a proprietary blend of something, something, something. Well, who knows? Is that sawdust? Is that ground almonds? Is that, what is that? You know, so I just urge people to be cautious about what kind of things they buy off the internet that don't have any kind of regulatory approval. So,
Yeah. Thank you
into
for
my
that.
soapbox.
Yeah, no, thank you for that. That's so important that
Yeah.
just for, reminder that none of it is regulated. None of it is, there's no proof other than the claims that we get marketing in general. And same for our special needs families that we don't know what the benefit actually is, if there is a benefit. So thank you so very much for sharing that. It's important. Yeah, well, we are just thrilled that you're with us and that you've been with us and you're committed to staying with us. You're
I am.
irreplaceable.
Yeah.
Yeah, you and the rest of the team, Nancy and others. They truly love our kiddos, and they are. You are all so important to us. We value your expertise and everything you have to share. So, thank you.
Thank you. Thank you. Great.
So I don't know. Looks like we haven't had any more questions coming in, so.
We've had a lot of good discussion generated in the chat
Yeah,
among
yeah.
families and
And,
with you
and
certainly.
I will, when I can get the actual website to the complete Nestle blended formula builder, the guy, I'm sure Paula must have had to step away from her desk, but I will send that in the general chat and you can share it with families as you choose to.
Okay.
Very ready. Well, thank you very much for letting me have a little soapbox here. And I hope to see you guys in a couple of years again. All right.
Yeah.
Thank you.
Or
right.
sooner.
Or
Or sooner. Yes, or sooner. Yeah.
Because we're working on some different things, but we're also, Susan and I do the podcast and stuff too. So we're talking about having folks on for the podcast, and that's always nice because it's more, I don't know, just a little more relaxed. You can kind of have that open discussion and stuff. But that's another way that we're going to hopefully get some information out to our families and stuff too more frequently than what we're doing now. So.
All right.
All right.
Well, thank
thanks
you
a
all.
lot.
Sign off here, and I'll try and log in again when Heather talks in a little bit of time.
Okay.
So, all righty.
great.
Thank you
Thank
so
you.
much. All righty. Bye bye.
Bye for now.
Bye.
So I believe we have a break where you can grab a snack and something to drink before we're back again from 2 to 3. We'll be talking about practical applications for family caregiving training back with Heather Roberts and JD, who joined us yesterday afternoon. And then a little later in the afternoon, we will have a session beyond bereavement. So we'll join you a little bit later and enjoy your break.
See you soon.
See you soon.